Good afternoon, everyone. Welcome back to the Advanced Treatments Agenda at Professional Beauty World. Thank you for joining us for this session on special considerations when treating black skins. My name is Georgia Seagull. I'm editor of Aesthetic Medicine, and I am joined by the lovely Shireen Bassel, who is founder and medical aesthetics director at My Skin UK. Thank you so much for joining us, Shireen.
Thank you for having me, Georgia.
So I know there is all sorts of education and some really great advice in this presentation. So I really hope you will enjoy it. I think it's going to be fab. A little bit of housekeeping. If anyone has any questions for Shireen during the session, if you could pop them in the chat box. So at the top right hand corner of your screen, you'll see the chat box. If you can type them into the tab that says page rather than expo, that would be fab, because then that would just be all the questions for this session in one place. Pop them in there, and then after the session, we're going to be going over to the Advanced Treatments Networking Lounge. Shireen will be coming with me, and we're going to be doing a Q&A in there. So you'll have the opportunity to also pop your camera on and ask her any questions directly, as well as I'll be reading out the ones that go in there during the session. So I'm going to get your PowerPoint set up, Shireen. Do you just want to give us a brief little intro to who you are and what you do while I do that?
Yeah, hi guys. So my name's Shireen Bassel. I am one of the aesthetic therapists at My Skin UK. I live and breathe skincare, and I treat all skin types, but today we are going to be looking at special considerations for treating black skin. I do all treatments ranging from peels, facials, permanent hair removal, and I also specialise in dermal fillers as well. So hopefully I will be taking you on a little journey as to, again, the special considerations that are required to look after these skin types.
Can you see my screen okay?
I can't yet, Georgia, but I'm just going to adjust and then I will be, yes.
You can see, okay. I am going to hide myself, start sharing this, and Shireen, you just let me know when you want me to change slides.
Awesome.
1 second.
I'm excited to be talking about this. So,
can you still see it?
Yes, I can.
Okay, cool. Over to you.
Thank you so much. I'm just going to move you over a little bit, Georgia, so that I can see the screen in full. Yeah, perfect. Okay, so I'm going to speak to you guys today about, I've got a PowerPoint here that I'm going to present to you that will hopefully take us on a journey to discuss a lot of things that I hope that I can cram into this session, but if we can't, then we will hopefully have some follow-up sessions for you. So without further ado, special considerations for treating black skin. So this presentation will explore the required special considerations for treating black skin. It's derived from true clinical industry experiences, medical references, and personal experience. So in this presentation, I will be sharing with you some of the things that I do day to day in my own treatment room, as well as looking at some medical claims and medical references that are out there. And hopefully we can discuss together some of the pros and cons of those and fuse those together with true personal experiences and apply them to the working environment in 2021. Next, please. So our agenda today will look at post-inflammatory hyperpigmentation, which we all know is quite a big issue in treating darker skin tones. We're going to be looking at editing black skin in 2021, skin types, skin conditions and scar tissue, common skin disorders, treatment considerations and options for black skin, physiological differences of black skin, and moral considerations. Next, please. So the big question is, what is black skin? I feel strongly that the question more pertains to who is black skin. We currently use a professional measuring system called the Fitzpatrick scale. And it's a clinical measuring system which ranges from Fitzpatrick type number 1 all the way to Fitzpatrick type number 6. And it's a scale that is used by clinicians to place the color of your own skin in a particular category so that we can decide how to best treat it. It's more commonly known for deciding how long it would take for that skin to react to UV sunlight. So black skin is clinically defined as Fitzpatrick types 5 and 6, usually, of the Fitzpatrick scale. In some instances, it ranges from mixed heritages to Asian heritages, and I find that skin types can vary greatly. So mostly we are in a Fitzpatrick scale of 5 or 6, but I find that that can actually change quite a lot, which is what we're about to see on the next slide now. Next, please. Thank you. So what you're looking at now is the Fitzpatrick scale, and it gives you an example of skin type number 1 on the far right, where you can see a lighter colored skin tone with red hair. This type of skin is described as seldom burns. And if you look at the opposite end on the far left, you'll see the skin type 6, which is more described as a deeply pigmented type skin that doesn't have any freckles and never burns. So this is a clinical indication of where you would sit in relation to how long it would take for your skin to respond to UV light. I find personally, some of the information is a very good guide, although it can be rather outdated in terms of what we actually see in the treatment room. So sometimes we do see darker skin tones with freckles. Sometimes we do see skin type 1s that can actually seldom have some elements of tanning. And we're going to explore that a little bit more when we look at melanogenesis. Next. I love this slide. I included this one because I felt that it was really important for you to be able to see real life patients in relation to the Fitzpatrick scale. Most of the scales that we see online are representative of models and photographs of things that are not very realistic, but this chart here indicates some of the patients that I treat, and in particular, I would like to draw your attention to skin type 4. Skin type 4 is a patient of mine who is of Black descent. She is of Caribbean and Cuban heritage, yet she is placed in the category that would otherwise be seen fit for an Asian skin tone. And as we know with Asian skin tones, Asian in an Indian reference or Asian in a Chinese reference, that can also vary greatly. And Black skin is no different than that. Thank you, Georgia. Next. So, like most skin complaints, the ethnic concern possesses the same characteristics of other skin scales, but they can be further heightened by a history of anxiety, anguish, and sensitivity, usually linked to a traumatic experience, dysmorphia, psychological and social stress. So, what we mean by that is that every client coming into our treatment room is equally as important. What I find with some treating Black skin tones is that sometimes the need and desire for treatment also encompasses all of this and a little bit more, in the sense that patients may have been told growing up that they were too dark or not light enough, and or too light and not dark enough. That may have been linked to an emotional stigma and a great need for social acceptance, particularly in this day and age where there are some suppressions taking place. And so I will explain that further in more detail also. Next. So before we go any further, we will talk about Black skin language. I feel this was a very important discussion for us to have because as professionals, we need to know how to address our Black patients or our dark-skinned patients. And so we're going to look at the different types of address which has taken place historically and that also takes place today. Next. Socially acceptable Black skin terminology for the treatment room in 2021. As practitioners, our clinical terms include the use of words such as the Fitzpatrick scale, brown skin, dark brown skin, highly melanated skin, medium skin tone, and deep skin tone. So this is how I and our practitioners here generally speak to each other when we're being descriptive about recording information about our dark-skinned patients. Geographical terms include African American skin, Afro-Caribbean skin, Moors, and Ethiopian skin. Historical terms include the words such as colored skin, red skin, yellow skin, ethnic skin, and fair skin. And those are very much indicative of yellow skin pertaining to someone who is very light colored or light browned person. And there is a stigma related to the word and the term colored skin, which has certain references to not a very good time in history for some dark-skinned patients, and it's a reference that some patients can take offense to. I personally do not take offense to that. It more rather highlights the error from where the patient has come from. So my patients who are age 70 or 70 and above tend to refer to that term, although I feel this is a very important slide for us to be able to come together as people in order to address everyone with the same clinical classifications which are necessary in order for us to work together more easily. So mostly the clinical terms that I've stated would be mostly acceptable. Next. Symptoms of Black skin conditions are often misdiagnosed or mistreated, leading to long periods of no treatment or the wrong treatment. If they're not treated early on, it can increase the risk of pigmentation problems. So this is not just a cosmetic concern, but the disruption to an important protective regulatory feature for the individual. So if we do not and cannot understand certain symptoms of Black skin, of course, we will ruin it. And in that process, we will make the symptoms worse for the patient. And also that's where we feel out of our comfort zones. We don't feel able to treat certain things that we are presented with. Again, it's not just of cosmetic concern that you could worsen or cause hyperpigmentation problems, but it also affects the Black patient or the dark-skinned skin type of that person by disrupting the way in which the skin regulates itself and protects itself, which is what I'm going to show you next. Next slide, please. So now let's look at a little bit of Black skin physiology. Black skin physiology is very wide indeed. I am going to try and home in on some of the key characteristics of things that I feel that you need to know as practitioners. And so let's take a look at that next. Firstly, I'd like to point out that there are not many Fitzpatrick's types 5 to 6 contributing to clinical dermatology trials, which seems to be one of the key problems in investigating conditions of Black subjects. Where they do, the number of Black subjects used are low, causing results, studies, and trials to become misconstrued or evident against testing subjects such as mice and comparable against outdated information. Now, a lot of what we found relates back to historical studies from more than 50 years ago, as opposed to what is actually happening now in our treatment rooms. And I've spoken to some of you who have informed me that some of the problems we face is that in clinical trials, they're just not broad enough, they're just not big enough. We have trials taking place with subjects of 50 people, with only some of those subjects being 12 Black patients, and therefore affecting the outcome of what we're attempting to seek to find. Next. So what is the physiology of Black skin? So we're warming up, guys. We're going to start looking at some of the claims that are made about Black skin. Next. Features of Black skin. So we're looking predominantly at a Fitzpatrick type 5 to 6. So for the purpose of this presentation, we would deem a Black skin in the industry as a Fitzpatrick type 5 to 6. However, we know that that can be very broad indeed and extend even to Fitzpatrick types 3 to 4 in some cases in terms of visual appearance. So some of the features of Black skin include increased photoprotection from the melanin found in the skin, a slowed aging process. A lot of people point out that Black skin tends to be quite slow in certain symptoms pertaining to wrinkling of the skin or dehydration. Follicle structure is exactly the same in all races. You will find normal varying depth in terms of the follicle or the curvature. However, all of the structures you will find in the follicle are the same. Black skin has a high lipid content. Some would agree that you can find quite an active sebaceous activity in some patients. Patients with bright colored eyes can absorb more UVR, more UV radiation than some brown skin patients who have dark colored eyes, leading to considerations of increased melanocytic activity. We have high eumelanin content. So there are two different types of melanin that you'll find in skin, in all skins, regardless of color or race. And you'll find that Black skin has a high eumelanin content, which can often reduce the photoproduction of vitamin D on the skin, vitamin D3. Black skin encompasses the same thickness as other skin types. Now, this is a very big one. A lot of people always talk about how thick is Black skin. Now, I will elaborate later, but I find that there isn't so much about the thickness. I would like people more to focus on the actual compactness or the density of Black skin. But yes, there are some variations in thickness. So for example, the stratum corneum of the Black skin tends to encompass 4 extra cell layers, so 20 cell layers, as opposed to the 16 layers found in white skin or some Asian skins. There is a higher incidence of distorted or infected follicles. So even though the follicle tends to be rather similar, again, in all races, you will find that there is a altered appearance when it comes to follicular structure, but that isn't entirely just down to the color of one's skin. It may be due to the compactness or the density of the skin or the way in which it is formed through melanogenesis, but the actual structure remains the same. there is indeed a higher risk of scarring and pigmentation problems. And there is increased photoprotection ranging from the darkest brown to the lightest brown skin. And there is also cause for concern that some people claim that black skin does not have common skin problems such as telangiectasia or the blood cell walls. When we talk about thread veins, people tend to find that they classify it as either being a non-existent problem in black skin because of the fact that it is very difficult to see. Next, please, Georgia. The slide that you're looking at here is descriptive of the way in which melanin is distributed throughout the skin cells in dark-skinned patients and also lighter-skinned patients. You will see that there is activity from what we call melanocytes, which take place in the basal cell layer of the skin, and they use melanocytic dendrites to rise the melanocytes through the epidermal walls, right the way up through the tissues to the keratin of the surface of the skin in order to distribute pigment. What you find in these two examples is that you'll see that the melanocytes in darker skin is distributed differently. They're dispersed differently by the time they form the top layer of the skin where the keratinocyte bonds resume. You will find also in a light skin or a lighter colored skin that they too also consist of melanin, but they are more closely packed into little envelopes in the cellular walls. One of the key things to remember here in dark skin is that the need and the form for eumelanin often is described as a darker tone or a darkly colored pigment, whereas in a light skin, there is something called pheomelanin, which is a different type of melanin, which is more responsible for the colors of a red or a yellow-brown hue, which is a lot lighter than the eumelanin, which is usually found. Next slide, please. Let's look at some claims to black skin physiology. It's thought that there is a transepidermal water loss. So it's found that there is a greater loss in skin water in black skin, which has, there are many claims out there to support this. And one of the claims that back this up is the way in which black skin grows. So one of the major comparisons that you will find is again through melanocytic technology. It's in the way that melanin reacts and grows and forms from the basal cell layers in order to protect black skin. And in the process of doing so, it is thought that black skin sometimes possesses a greater transepidermal water loss for two reasons. One being through the excitable activity and the accelerated activity through melanin. And the second being that there are less ceramide bonds to retain that water in the skin. So we have a high lipid content, but then a very low and broken ceramide bond within black skin, which leads to other claims such as black skin being quite dry and having conditions such as xerosis, which is, we will look at some conditions later. Other claims include skin shedding and desquamation. So black skin has a 3% faster skin rate of getting rid of and shedding dead skin cells. Black skin also has in structure what we call a larger mast cell design. And this is probably one of the claims that also backs up that density to black skin. So one of the claims is that by having larger mast cells, larger dendritic activity, we find that the depositing of melanin throughout the skin tends to cause a variation in how fast our mast cells react, which can have a reaction on our gut and our immune system, and therefore heightened sensitivity in black skin, therefore deeming it more sensitive in some ways. Last but not least, we also have to consider the pH value of black skin, which has been thought to have a lower pH level versus all of the other skin conditions, all of the other skin types, white and Asian skin. Next slide, please. We're going to look at some of the conditions that patients with darker skin tones come into the treatment room and tell us about. Post-inflammatory hyperpigmentation, so dark spots and the feeling of permanent dark spots on the skin. So for some patients, they feel like they just will never shift, they never go. We will look at melasma, an uneven skin tone and discoloration. Facial folliculitis is a common issue in the treatment room. So issues pertaining to ingrown hairs and bumps, that comes up a lot with both male and female patients. Pseudofolliculitis barbae, which is ingrown hairs and bumps on the skin. I tend to encounter a lot of those from my dark-skinned male patients. Acne chalidoides nushi. Now, this is a condition that I've come across several times. It can actually be quite debilitating. It's not a nice condition to have. They represent as acne looking but keloidal scars that can actually form anywhere around the scalp, and they often lead to the next onset, which is alopecia, which is another common condition associated with some patients with dark skin due to the way in which the melanin activity comes about, due to the way in which the mast cells induce inflammatory responses in the skin to support all of these things together, which we'll look at in just a moment. Keloids and also eczema and pruritus. Next slide, please. So, a list of common skin concerns for black skin include excess hair growth, particularly to the chin, the jaw, and the neck, acne, post-acne scarring, pigment dyschromias, so concerns to do with melasma, post-inflammatory hyperpigmentation, scar tissue. Hypertrophic scarring is a pretty big one too. Hypertrophic scarring, we tend to find that due to the vast activity in the way in which melanin fuses together and its rapid activity, its rapid energy within the cell often causes scars and scar tissue to have an accelerated growth or an accelerated rate of healing, which therefore causes scar tissue that can sometimes deem difficult to treat. We will also look at permanent depigmentation of the skin, so not just post-inflammatory hyperpigmentation, but we also counteract hypopigmentation as well. Stretch marks, dark circles is a very big concern. Darkness around the perioral mouth, dryness and dehydration in black skin, balding, sunburn and windburn, eczema, and products as well. So these are all common skin concerns that we talk and hear about in the treatment room. Next, please. Now we're going to look at turning some of these things into the special considerations that should be taken when a patient enters into the treatment room. Next slide, please. We have a whole host of different types of conditions. So the slide that you're looking at now is a list of what we would classify as inflammatory conditions for the skin. And I'd like to point out that inflammation on darker skin tones tend to exude themselves as hues of red or purple irritation. And they can often seem either raised or infected, versus erythema that again can exude hues of red or purple on the skin. But there are very big differences between what inflammation looks like in the skin and what an erythema looks like on the skin. And it's important for you to know how to tell the differences apart from both of them, because then that will be your deciding factor as to how to treat the skin and your choice of treatments. So I have some slides coming up a little bit later on that will point the differences out for those two reasons. On this slide, you will see there is acne, cystic acne, ingrown hairs and follicle infection, eczema, and sunburn. How we treat acne consists of a numerous amount of things. You would need to do well to have all of your testing materials laid out in front of you. And so when we go through the next slides, I will go through some of those key things. I would just like to take a moment just to look at in how we're treating acne. So keeping your acids low is one of my pro tips. When it comes to using peels and lasers against darker skin tones, definitely we want to tread carefully with moderate to mild considerations. I find that a lot of people tend to run away from using products such as TCA peelings and the stronger versions of peels to treat certain skin conditions. I will go through that in my later slides. When it comes to ingrown hairs and follicle infections, the best courses of treatments for those consist of peels and low-level laser therapy and different combination peels. I think we are very used to using one set type of peel from product houses, and we are not feeling comfortable with combining our peels and mixing them and becoming aware of the different concentrations required to treat the skin condition at hand. Next slide, please. We also have to take special considerations for pigmentation. So looking at conditions such as melasma, we tend to use the choices of glycolic, lactic and mandelic acids. I tend to keep these within the ranges of 20 to 35% when I'm treating someone for the first time. I do consider using Jesner peels for deeper pigmentation, depending on the form and the nature of the melasma, of course, and depending on the individual needs of the patient. Again, keeping your acids low for this type of patient. TCA peeling can be acceptable. I tend to stick to a concentration of around 15%, 10 to 15%, although that varies depending on patient need. For post-inflammatory hyperpigmentation, I really like to use a combination of more gentle combination peeling. So my salicylic and my lactic acids of around a concentration of 5%. In many cases, again, mandelic acid can be a great choice. It keeps it low. It doesn't provide a great inflammatory response, which is not what you want to see in a darker skin tone. Hyperpigmentation, with any skin condition, you want to really focus on prep. Okay, so I think there needs to be a special consideration for encouraging patients to prep the skin even prior to permanent hair removal, encouraging and informing the patient of the products and the pH value of products that you want them to use prior to essentially attempting to correct the apoptosis. Vitiligo is another concern. So patients presenting with vitiligo, low-level laser therapy. I am well versed in laser therapy. I find that to be a very good medium of a range of photolight against vitiligo. There are also oral prescriptives that can be used to treat this condition also, which would require certain prescriptives. And I have a list of those also on my website that I will share with you later on. Next slide, please. We're also just going to take a look at how we treat certain blemishes and disorders of black skin. There are many different types of warts and moles and different things that can present themselves when treating the face or the body. Next slide, please. Some of the common concerns, so these are one of the 4 main concerns that I come across when treating darker skin tones. Keratosis pilaris, very common in the armpits of dark skin patients and often seen represented throughout other folded areas. So you can even sometimes come across those that look very uncomfortable, mainly towards the armpits or in folded areas like the neck. I find that electrolysis, hair removal can be very good at correcting the follicles where you get a very heavy buildup of dead skin cells, causing the skin to look lumpy and uneven. I find that patients who represent with moles, now moles is a very big one, moles and associated lesions I do treat very cautiously and with great utmost care. For myself, I use a range of testing devices. One of my favorites has to be a dermoscope device, in which case I make a very great classification from differentiating from what a mole or a papulosa nigra may present and look like on the skin. I have come across therapists who have tried to squeeze moles, who have tried to squeeze papulosas and associated black lesions or black dots on a darker skinned patient. And it's very important that you know the differences between these guys, as we know. We want to protect against advanced skin cancers in the discerning patient. So advanced electrolysis can be used to treat moles, but first and foremost, I do recommend that everyone has a little insight into the variety of how moles and different lesions can look on dark skin, which again, I will show you later on. Papulosa nigra represents as black spots, often commonly associated around the eyes and the sides of the temples, and we also have filiform warts as well. So a variety of different warts that can develop on the face. Next slide, please. Next slide, please. Due to the cautions and inexperiences associated with black skin, the practitioner tends to either attend to the skin incorrectly or too delicately, with the client left feeling deflated due to slow treatment progress or with the impression that the therapist does not understand how to treat their skin conditions or their skin concerns. So one of the things that I hear about from patients with darker skin tones is that they have either had previous treatment to which the due diligence and care was not undertaken in order to thoroughly understand the nature of the condition, which therefore led to the ruin of the skin and the permanent damage of certain skin tissues, which I myself have tried to, and as you have as well as practitioners, try to refine and correct. And those patients are often left feeling really deflated. Or what they find is that they go to some practitioners who, due to caution, treat the skin so slowly or so gently that they find that the treatment is very slow and that there is no progress being made whatsoever, again affecting and having an impact on the mental psyche of the dark-skinned patient. So let's take a look at different things that will help us to understand how to treat those types of patients. So we want to start with a thorough consultation of black skin. So visual observation categorically places individuals within a Fitzpatrick scale, but it doesn't always explore the ancestral trait of where the patient has come from. We're living in a time where we have a lot of mixed heritage. We even have people who are exercising their freedom of speech to decide what they would like to be called. I've had patients in the treatment room who have decided that no, they are not a black patient. They will not be put in a box of Fitzpatrick type 5 or 6, or they will refuse to be known or associated with black skin. And so we need to really think outside the box and broaden that insight a little bit more by asking the right questions to obtain their heritage and to obtain where and what and who they've actually come from in order to determine how we're going to treat their skin and to help with DNA assessment. Next slide, please. Before we look at special considerations for chemical peeling, it is very important to note that in 2021, we should be looking at the constituents of black skin in line with the Fitzpatrick scale of looking at skin tones and types. The constituent of dark skin tones tends to look more towards the DNA of the skin and how it's made up. And there are certain ways and questions that we can ask to ascertain where our patients come from in order to find out how we're going to treat and care for that type of skin. Next slide, please. So here's a list of a few things that we should be looking out for, a few special considerations for the treatment room when you are just about to treat a dark-skinned patient with chemical peeling acids. We want to be clear in identifying the patient expectations and the realistic outcomes prior to the treatment taking place. I often have to send patients away to prep the skin prior to certain considerations around peeling. I want to ensure that they understand the process of what they're getting into. I want them to understand the realistic outcome and expectation that they may want to receive from a treatment or consultation with myself. So I find it's very important to discuss the realistic outcome. With some skin tones, you know, the pressure to want to appear as a smooth or an even skin tone, or in some dark skin patients to ascertain to a lighter skin tone must be discussed and considered prior to consultation. So we've spoken about adequately prepping the skin and ensuring that the patient is not using products which are too harsh. I find that some patients are using very strong products, soaps, tea tree oils, alcoholic toners. They're using completely and identifying incorrectly with the wrong products that tend to take a lot of hydration out of the skin, leading to patients that have quite a dry xerosis type of skin type and a dehydration. I also always want to know what products that they have used previously in the past before considering treatment, and I want to make special recommendations for retinol. So retinol has to be one of those ingredients that if you're attempting to treat it with black skin, I would always say start at a similar 0.25 concentration. I would never jump to 1.0, regardless of what I feel that I know about that skin. I have done so in the past, but I would make special considerations for that alongside whatever treatment I am planning to do. A retinal disaster in a dark skin patient will result in a huge mass of dark hyperpigmentation that could take weeks or even months to correct and rebalance itself out. And of course, special considerations would need to be taken for UV application, which is a very key feature of black skin. Next slide, please.
Shireen, I'm so sorry, we're running out of time and I want everyone to see your before and afters.
Can we jump to the before and afters, please, Georgia? I did say we've got a lot to cover, so
we'll go over anything else in the lounge after, but maybe 1 or 2 minutes to go through
absolutely. So this is really where I wanted to get to. So you will see that we have some photographs here. This is a before and after of a treatment that was performed focusing on post-inflammatory hyperpigmentation. It was the use of a 30% lactic acid treatment, and special considerations here was that I required this patient to prep the skin 2 weeks prior to having their first peel, and then we actually brought the peel up quite close to the eyes within the orbital rim, with special considerations for not getting it into the eye. Next slide, please. You will see here that with this patient, this was a consideration for melasma. Melasma in this case, special considerations consisted of applying certain SPFs of a concentration of a minimum of SPF of 42. This was a consideration after 1 treatment. And that was the temporalis area that we treated. Next slide, please. Georgia, I'm just whizzing through at the minute. We have a before and after again. This was after 1 treatment. This was a lactic acid at 30% concentration. The key areas here were to treat blemishes and congestion of the skin. Next slide, please. This was a microneedling patient. We performed medical microneedling, and you can see how the skin responds in an inflammatory sense. So before, we wanted to pay attention to melasma, papules. Patient had special consideration for dark circles around the eyes also, and you can see the after results of how the skin responded. I would also say with microneedling to keep settings low. We went in at a 0.25 to 0.5 needle depth, millimeter depth for this patient. Next slide, please. Here you can see some treatments using advanced electrolysis on the right-hand side to treat congestion in the skin and inflammation of acne. And on the right-hand side, this was the outcome of a TCA peeling before and after treatment. Next slide. This is considerations using advanced electrolysis. Again, we have a filiform wart on the right-hand side to the patient's forehead, and we have papulosa nigra on the left-hand side around the eye area, with special considerations for the application of SPF afterwards. Next slide, please. Here we have medical microneedling again, before and after, for patients with a Fitzpatrick type 5 skin. And this was for the treatment of, we have some large sebaceous pore sizes. We also have some pigmentation considerations, and we have some scar tissue considerations here too. Next slide, please. Before and after of a glycolic peel this time, as opposed to a lactic acid peel, we had a very good response in erythema and with some indications for inflammation to the skin. And you can see in the after results, by keeping the acids low, this was a 20 and 30% glycolic application. And this was for skin rejuvenation and the treatment of fine lines and wrinkles. Next slide, please. Microdermabrasion application in patient to the left after one treatment, only going over the area once or twice, never repeat several times of excessive abrasiveness that will stimulate extra melanocyte activity. And to the right, I can see here that we also have an after result, and this was considerations to do with microdermabrasion again. Next slide, please. Glycolic peeling, patient before and after, special considerations to fine lines and wrinkles and hyperpigmentation, one treatment. Next slide, please. To end, I didn't know I could do that. The formula for special considerations will always consist of this formula here, which is really to make sure you're doing your due diligence around consulting with your client, asking the right questions, digging deeper for DNA considerations, as well as looking into suitable prep work, ensuring that they're on the right pH balance of products and glycolic forms prior to certain considerations to do with low-level laser and certain types of electrolysis work and laser work, as well as professional medical microneedling, and ensuring that you follow up with aftercare as well. And the application and the importance of sun protection within the dark-skinned patient. I do feel, Georgia, that I'll probably have to do another session on that because there is a lot to talk about, or you can just join us in the lounge area where we will happily answer more of your questions.
Thank you so much, Shireen. I'm so sorry I had to rush you because that was great. We're having lots of really good feedback. So let's go on over to the Advanced Treatments Lounge. I'm going to ask you questions and people can ask you questions, or we could go over anything. I had to rush you, but thank you. That was amazing.
Oh, thank you so much, Georgia, for having me. That was amazing. I didn't even know I could speak that fast.
You just flew through it. Okay, let's go into the lounge. Thank you, everyone. Thank you.
Oh, thank you. Take care. Bye-bye.